be extremely thankful to the commitment and sincerity of MSN Labs for arranging this webinar in these tough times of COVID. And we're not able to go out because of lockdown, but still they manage this. And the lockdown period, which is social distancing and various other modalities of separation, but it can't socially isolate us. This technology helps us. I think all of us through various countries here. I see 149 participants logged in. The 150 now, it keeps on going. It's a great thing. I think I will just briefly introduce the other moderators and panelists here. Dr. Adibi is head of cardiology unit from University College Hospital, Nigeria. Welcome, sir. Dr. D.M. Kilingo is again physician, cardiologist, and lecturer, Department of Internal Medicine from Egerton University, Kenya. And my good friend, Dr. Shamla Lumesh, and we had opportunity to interact with him before. And head of the department, SSH RNH Hospital, President, Cardiovascular Society of Mauritius. Always welcome for any such interactive programs. We had a chance to meet him before. And again, thank MSN for bringing him, all of us together. And before I start my lecture, I would request Dr. Shamlal and other moderators, the panelists, to say a few words. Over to Dr. Shamlal. Were you able to hear, sir? Hello? Shamlal, I can see his video again. Okay. The other panelists, anybody who can, Dr. Adibi, I can see. I think his voice was coming before. Dr. Adibi, Dr. Kilingo, and Dr. Oga was also here.
You?
Yeah.
Yes,
please
Dr.
welcome
Oga.
to this webinar, sir. Each of you can say a few words before I go and take on my lecture. Then we'll have like question and answer session after the talk. I think each of you can briefly say a few words before we start my lecture. Okay.
Thank you very
so
much.
Today, what we thought we'd discuss is about something about heart failure. We titled it as Mastering Complexity in Heart Failure, basically to highlight and stress the importance of Eplerenone and Tolvaptan. And again, I congratulate and thank MSN for organizing this in these tough times. And this is Apollo Group of Hospitals, Apollo, my colleagues at Apollo and Fax Foundation. I thank all of them for taking care of patients, and we work like a team so that all of us can interact and do good to the patients. These are other hospitals which our team covers. We are happy to say that we are about 27 cardiologists, 3 cardiac surgeons covering services in multiple hospitals. This was recently appreciated in European Heart Journal, and Apollo was also very happy because they also came in European Heart Journal. I feel strongly, especially in these tough times like COVID, if we have a group like this, is a great help to help each other and to take care of patients. Coming back to the agenda, the topic of today's discussion, I would briefly go through in the coming 20 minutes or so. What I would do is basically define heart failure, what are the various types, systolic, diastolic dysfunctions, preserved ejection fraction fund, and tell you briefly about the epidemiology of various statistical data of the heart failure across the world and in India, and briefly highlight upon pathogenesis and the causes of disease progression and hospitalization, which we tend to see in these sicker patients. And functional class and staging of heart failure, there's a slight difference of it. I would like to highlight this aspect again, as though many of you know functional classification of heart failure. The staging is one which is proposed to highlight the preventive aspects of heart failure. And briefly tell you about symptoms and signs of heart failure. And some of the cardiologists who have logged in could think it as basics, but I would request them to excuse us, because as I was told that some physicians and practitioners also are joining. It's very important for us to detect heart failure clinically. And that's how I briefly touch upon that. And various investigations which are recommended in the initial workup as well as later, and how to manage this pathway. European Society guidelines, other guidelines I would briefly mention, and also a word about management of comorbidities. After this, can others mute the mic, please? All others mute the mic, please. Okay. So then, finally, I will go on to this, touch briefly upon this newer drug, which is Arni, which has come in heart failure, and re-stress on the older drugs again, because it's very important for us. It's useful in about 40-50% of the patients. The Eplerenone, which is especially proven its value in post-MI LV dysfunction, and the Tolvaptan, which is a very useful addition in day-to-day clinical management of heart failure patients, especially who have hyponatremia. So we'll spend little more time on these two molecules, because those molecules are the ones which has brought us together across various countries. And finally conclude showing some key messages about heart failure and about these two individual molecules. That would be my plan of discussion. And then, as we know, to define the heart failure, any function, any organ, if it fails to do its work, it is called as failure. Heart pump function is to pump the blood or relax and get the blood in. So either any structural abnormality or functional impairment where the heart cannot fill itself or eject blood. This is what is heart failure. So this is ACSHA. European Society made it more clinically oriented, said the clinical syndrome characterized by these typical symptoms of breathlessness, edema, fatigue, and accompanied by the signs like JVP raised and pulmonary crackles, peripheral edema, again resulting, or the heart fails to do that function or can do that function with increased pressures, with right heart pressures increasing. So this is what is the classical definition of heart failure, as we know. If you see, when we were students, we were aware of only the systolic heart failure. But we come to know that a significant, about more than half of these patients have preserved ejection fraction, but still have symptoms of heart failure. That's where we became wiser and we come to know as diastolic dysfunction before. Now we call it as heart failure with preserved ejection fraction. That is HF-PEF. So if you have ejection fraction of more than 50%, and we generally consider it as heart failure with preserved ejection fraction, with less than 35-40%, it is reduced ejection fraction. That is what is classical systolic dysfunction. So you might be wondering, there are some group of patients which have in between this function, 40-49% of ejection fraction. That is basically the mid group. So now we devise a newer term called heart failure with mid-range ejection fraction. So that is all the three subsets of these patients, and predominantly this is done by echocardiogram, as we know. So then if you see the progression of heart failure, no heart failure patient can be stable, you can think. Suddenly they can decompensate and worsen, and many such events happening like this, chronic declines, repeated hospitalizations, suddenly increase mortality. This is by disease progression. So main point of focus is to etiopathogenetically modify this disease progression so that we can save these patients. So if you see any patients who have worsening of symptoms, and can have 5 times mortality, and the symptoms require so bad that require hospitalization, the mortality increases 6 times. We are aware with the analysis of the data now. Then if you see any heart failure patients, initially at first admission, he can have 4-10% mortality, and about 30 days, 10-15% could die, and mortality at 1 year, about 30% could die, and about 5 years, and about 50% of them could die. That is the seriousness of this entity of heart failure, especially systolic dysfunction. If you see, we are so much panicked about this cancer. The term cancer itself raises hair for us, and we all become very careful. But if you see it, I am not saying that importance should not be given to malignancy and cancers. It's also there. But breast cancer has a mortality of 10%. Hodgkin's has 14%. As it goes on, colorectal cancer about 34%. This is about 5-year death rates I'm talking. Whereas if you see our heart failure, 48%. That means half of them would die in 5 years if we don't take care of these patients. So that is to say that this heart failure is more deadlier than many cancers and more malignant than many malignancies. That's why it's very important for us to know what is the right way to treat these patients. If you have to see the burden of heart failure, we have globally about 37.7 million people suffering with heart failure. And every year we have addition of about 870,000 new cases every year. The prevalence of heart failure, as we know, increases with increasing age. And if it is more than 65 years, 1 in 6 patients would suffer with heart failure. And many times, breathlessness of many of the times in elderly people could be unrecognized. Many of them get treatment as a bronchial asthma and things like that, and that is actually could be unrecognized heart failure. That's why it's very important for us to recognize what it is. And as the age increases, as the age of the person increases, it is more than 55, 33% of the men and 28% of the women would suffer with this heart failure. and mortalities increase with increasing mortality rate after 5 years of initial diagnosis. As I said, 50% of them could die. That's the importance in burden of heart failure. A word about Indian heart failure. Word about Indian heart failure patients. India, as you know, yeah, can you mute your other mic? Okay. So India, as you know, is the second largest population in the world, about 16% global population, and about 20% of the burden of coronary artery disease in India, and hypertensives are also 120 million, as mentioned here. So if they see the important risk factors of India, CID and hypertension patients, even if 5% of CID patients or 10% of hypertension patients goes, it becomes huge number in contributing to this heart failure. Though rheumatic heart disease is decreasing, it's a welcome trend in the country, but still could contribute some of these patients of heart failure. The other peculiarity of Indian heart failure is these patients are young compared to many other countries, and about 1/4 of them could get readmitted once, and 5% or so get readmitted more than once in a year. And that's how every 1 out of 3 patients gets readmitted every year. That is very important to prevent rehospitalizations. If you see what is the main reason, if you give proper guideline directed therapy, it will cover up on soon, immediately.
Parce
If
que
you
mon
give
pétardé,
proper
mais
therapy,
mon pas pétardé qui est causé. Moi, tu connais
the technical team, you
voix
can
comment
mute
dire, mon pas
others'
pétardé
mics,
qui est
please.
causé.
You said you have the facility to mute others' mics. Please mute all other mics. Once the talk is over, you can release the mic. Okay. So if you give the heart failure the proper guideline directed therapy, you can significantly decrease the mortality. That's very important to give proper therapy to these patients. If you see why are these patients readmitted, who are those who are getting increasing mortality is increasing age, anybody who has associated stroke and high creatinine, and medical therapy is not being given, hospitalizations repeatedly happening. Those are the patients who have very high mortality. So this repeated hospitalizations is an unsolved problem yet, and that's how more and more patients stay in the hospital. If you see why these patients get readmitted, we need to know this, because once you know the cause, you can prevent some of those from happening. These disease-related factors, which is unfortunate, as the disease progresses, heart pumping worsens, and sometimes in between arrhythmias, coronary syndromes could happen, leading to this problem suddenly. And hypotension, blood pressure falling down could lead to kidney dysfunction, other things, and worsening renal functions. And that's how heart failure gets precipitated. These, though we can have some drugs to prevent this, but still this is a reasonable thing to have if at all the patient is having. But what we need to immediately see is the system factors, the type of therapy which we offer. Suppose inadequate follow-up, we don't see the patients on follow-up, we don't do discharge planning and give medicines on follow-up. Unfortunately, if you see many patients of heart failure who get discharged, you may not have ACE inhibitors or beta blockers written. So these sort of errors should be avoided. And the patient factors, this is again unfortunate. Many patients are unaware. Once they improve, they decrease the medicines or stop the medicines, then they suddenly land in trouble. This is drug non-compliance and poor health literacy aspects of patients is another very important thing, which leads to repeated symptoms worsening. And diet is important. Fluid restriction, salt restriction is important in these patients, go a long way. This we know many of the times just patient admission itself in the hospital, taking rest itself improves a lot in these heart failure patients. So all these things which are totally preventable from the patient's point of view, from the doctor's point of view, are very important for us to understand. And some disease-related factors, obviously, whichever we can take care, we should try to take care. So this is what I mentioned. Guideline-directed medical therapy to give, it can significantly improve outcomes of this patient. Coming to types of heart failure, as I mentioned, systolic heart failure, less than 40%, and preserved ejection fraction heart failure, more than 50%. Mid-range is in between 40 to 49%. If you see the symptoms and signs are present in all of these, and here, mid-range ejection fraction, preserved ejection fraction basically are diagnosed by having structural abnormality or diastolic dysfunction on echo with these elevated natriuretic peptides, which are now of prime importance in diagnosis. If you see pathophysiological basis for heart failure, I won't bore you too much with pathogenesis. But basically, whenever leads to failure of more of vasoconstriction. That's how the worsening tends to happen. All these years we were planning only on this pathway, RAS blockade. Now this new molecule RNA which has come prevents this degradation of this pathway, this molecule, and that's how the patient do well on the follow. Then if you see the signs and symptoms, I would spend some time here for the sake of all our doctor colleagues, physicians, and practitioners here. As we know, many of them will have typical symptoms of breathlessness, and especially this breathlessness when the patients increase on when he lies down, that is orthopnea, or gets up from sleep, paroxysmal nocturnal dyspnea. These are very typical of cardiac breathlessness, unlike other causes. And sometimes they could have just fatigue. And edema, again, many times this ankle edema or facial puffiness also could be because of heart failure. The less common symptoms are weight gain, and sometimes if patients become too cardiac failure persists longer, it becomes cachexic, and again you have various types of tachypnea, tachycardia, ascites, cold extremities, and frequent micturition. All these could be sometimes that less common things which are presenting. Bloated feeling, loss of appetite, all this. Some of the specific signs of these patients who have are elevated JVP and liver enlargement, third heart gallop, and cardiomegaly. Whenever you find an examination, you have heart dilated, that again suggests that patients could be in heart failure. So these are some typical symptoms and atypical symptoms and signs of heart failure, which is important for us to recognize. To classify heart failure, as we all know, New York Heart Classification, which is there ever since long. Basically, if you remember ordinary activity, if symptoms are there with ordinary activity and with mild symptoms, class 2, more than ordinary activity 1, less than ordinary activity is class 3, and even at rest somebody has severe limitation of symptoms, it is class 4. PND falls into class 3 and orthopnea falls into class 4. Another important concept which we need to understand is staging of this heart failure. Staging of heart failure is basically proposed with the idea of preventing onset of heart failure. Stage A is you have the risk of development of heart failure, but no structural derangement has happened in the heart. Like patient is hypertensive, coronary artery disease, diabetes mellitus. Anytime these patients could go into structural abnormality and heart failure, but as of now not. And then patients who have structural heart disease, but yet not developed symptoms. This is asymptomatic LV dysfunction or hypertrophy. Asymptomatic valvular heart disease falls into this category. And type C is again stage C is structural heart disease, again with symptoms, but manageable. This is what is a stage C of heart failure. And stage is refractory heart failure requiring repeated interventions, hospitalizations. These patients require inotropic support. Some of them could go into these mechanical assist devices and all. If we can identify in the stage A and give the treatment properly, we can prevent the occurrence of structural deterioration, and we can prevent the occurrence of going into the symptomatic stage. That's importance of knowing the staging of heart failure. So diagnosis of heart failure, again, to mention basically to suspected signs and symptoms which this patient has. Clinical examination, you take an ECG, you get chest X-ray, and whenever you find these signs, and if you have facility, you do natriuretic peptides. And if NT-proBNP is more than 125, BNP more than 35, this could vary with labs and type of checks which you're doing. And if they're elevated, it confirms the diagnosis. If it's not, then probably you're dealing with something else. Then you do an echocardiogram. We will be diagnostic of both systolic and diastolic heart failure. That's how the workup happens. Coming to what are the various blood tests which we need to do in these patients according to ESC guidelines. Basically hemoglobin, because we have a lot of data now to show that low hemoglobin itself could increase the mortality in patients of heart failure. Sodium, potassium, creatinine, again, these have significant implications in the outcomes of patients. Worsening creatinine is a higher mortality factor. Alterations in sodium, potassium indicates functional derangements in these patients. That's why important to check. And liver function test, because liver gets congested and it becomes deranged. In glucose, HbA1c, again in patients.
Yes, Charge.
you might take the help of right heart catheterization. Endomyocardial biopsy, again, is not a standard thing. Very rarely it is done. But sometimes when you suspect cardiomyopathies, undiagnosed problems, myocarditis, you could do it, especially more time of the time it is used in heart failure follow-up patients and post-transplant patients. Ultrasound examinations, again, are useful to identify IVC status and fluid collection in the lungs. So that is about symptoms, signs, and various tests which we do. And coming to what are the goals of our heart failure management, basically to prevent patients going into CHF, obviously, detect asymptomatic LV dysfunction early and treat them, as I said, relieve symptoms and signs and improve the quality of life. Patient is unfortunately symptomatic already, slow the disease progression and prolong the survival. We have very good drugs now, which we do this, and improve physical activity tolerance and reduce hospitalization. These are our goals of management of heart failure. What all we do it, basically non-pharmacological measures like decrease fluid intake, encouraging physical activity, limiting salt consumption, avoiding alcohol, absolutely, stop smoking, avoid stress, and giving these vaccines, pneumococcal influenza immunization helps in non-pharmacological measures in heart failure. Pharmacological measures, we touch upon a little more in detail, ACE inhibitors, ARBs, and mineralocorticoid receptor antagonists. That is the topic of today. About Eplerenone, we'll touch more on this. ARNI, diuretics are used. Implantable devices are again for end stage, for LVAD or with incremental therapy and ICD. If you see the clinical effectiveness of the various these drugs, that's how the drug therapy has made wonders in these patients with heart failure. If we can give all these guideline-directed therapy like ACE inhibitors, receptor blockers, ARNI, beta blockers, and mineralocorticoid receptor antagonists, we see 63% reduction in mortality. That's a very good thing which these patients can have, and provided you give them in the right dose. It is the guideline directed pathway, which is mentioned here. So ACE inhibitors is recommended, and then you add beta blocker patients slowly. If the patient is stable enough, probably beta blocker is recommended in addition to ACE inhibitors. In other words, to say addition of beta blockers after right stabilization, and then next step is an addition of MRA, mineralocorticoid receptor antagonist. In previously it was splenectone, now it is Eplerenone. I would take you to this right side chart in a bigger way here. The patient who is symptomatic, initially put them on ACE inhibitors and beta blockers, and some of them who still have symptoms, probably ARNI could replace that. And if QRS duration is long, these people go for CRT, and if heart rate is still high in spite of using beta blockers, this will go into ivabradine. And this right side one shows diuretics are continuously used to decrease the symptoms. And whoever has a history of sudden cardiac death, arrhythmias, they could take the help of ICD. That is the basically management protocol pathways which we use in symptomatic heart failure. Then if you go and see, this is ARNI. As I said, previously we were trying only receptor blockade pathways. Now we are trying to decrease the breakdown of these useful molecules of vasodilatory molecules, so that vasodilation happens and more patients' heart likes it, because vasodilation helps. And these patients not only blocking the receptors on the bad pathway and prevention of the degradation of the good molecules also helps a long way. That's how ARNI is found to be useful. This data came in Paradigm Heart Failure. More than 10,000 patients were randomized to ARNI versus enalapril. So then these patients who were put on the ARNI, more of them had significant reduction in death and hospitalizations with heart failure compared to standard ACE inhibitors. That's how the Paradigm Heart Failure said that this ARNI could be alternative or in fact better than ACE inhibitor therapy. If you see this graph which shows ACE inhibitor receptor blockers could decrease mortality only in 15%, but if you add this ARNI therapy, the mortality is further decreased by another 20%. That is about the various drug therapies which we follow. Another word which I would like to mention, apart from these various drugs which are used, is some of these comorbid pathologies like hypothyroidism, hyperthyroidism, and anemia, which could again worsen these patients. So if you find this iron deficiency or this patient being anemic, not only the oral iron, this giving IV ferric carboxymaltose is also supposed to be beneficial. Now, the last 10 minutes or so, I would like to stress more upon the topics of today's interest on these two molecules, aldosterone blockers and also Tolvaptan, which is actually known for all of us as a drug which is useful for hyponatremia patients. So what we have understood after these patients who are put on ACE inhibitors or receptor blockers, many of them have responded for some time, but about 40% of them again started worsening. When they tried to analyze why this happened, This is what is the aldosterone breakthrough phenomena is what is noted, and patients somehow this pathway again becomes activated. That is because this experience of aldosterone breakthrough. So when they see it again, increased events happening, reduced exercise capacity, and these patients are worsening over a period of time. So that is how it's very important. Patients who are all right before with ACE inhibitors, receptor blockers, having worsened, now you have to think of this aldosterone escape mechanism, and that's how we titled this the Mastering the Complexity. Previously, it was only spironolactone, but now you have better molecule with cheaper price thanks to MSN. This eplerenone is almost replaced the spironolactone because of less of side effects of this molecule. What is this eplerenone? Is an oral aldosterone antagonist indicated for treatment initially for hypertension. Now it's predominantly for heart failure. Especially, it is found to be very useful as first-line therapy for heart failure secondary to myocardial infarction. That is what actually is came into limelight. And mechanism of action, as I said, is mineral corticoid receptor antagonist, and thus inhibit sodium reabsorption, and other deleterious effects are also prevented. See the pharmacokinetics of this drug, we should be knowing that cytochrome P450 mediated metabolism drugs like erythromycin, ketoconazole could interfere with this metabolism. Elimination half-life is 3 to 6 hours and reaches a steady state within 2 days. That is, you start a molecule, within 2 days, patient could have the benefit. So the place in this therapy of the eplerenone is whenever these patients of heart failure were not doing well, especially after this escape phenomena, again, you think of this molecule. Heart failure after myocardial infarction, again, they have study, I will get that to you. Immediately from day 3 itself, this did good. So eplerenone is again selective aldosterone antagonist with less incidence of hormonal side effects which are seen like with spironolactone. So if you see the dosage of administration of this molecule, initially 25 milligrams once daily and titration gradually within 4 weeks up to 50 milligrams. But if your patient is more sick with lower blood pressures, probably you can start with, we in India tend to give little lesser doses, start with 25 milligrams half a tablet and go up to 25 and then step up to 50 with time. In hypertension, again, if patient's blood pressure is all right, you can start with higher doses, 50 milligrams, and go up to twice daily also if you are giving it for hypertension indication. Mind you, if you have somebody has resistant hypertension, we need to try one of these molecules before you call anybody as resistant hypertension. So that is the importance of knowing about this molecule in hypertension. Then one caution which people initially thought is this molecule, how that is behave when you have potassium abnormality, because we know that some of these, because sodium potassium mechanisms is inhibited, there could be slight increase in potassium value. But what is noted is important clinically is many of the times very severe increase more than 6 is very less likely, which I will show in some of this trial data. Most of it is what is increasing in between 5 to 5.5, which does not have clinically too much problem. If a patient has less than 5, probably regular dosing you can continue of potassium. And if a patient just started increasing, you should be on the lookout. And if it is in between 5.5 to 5.9, probably you would half the dose. And probably if it's already on a small dose of 25, we withhold it. And once the potassium comes back to less than 5, you start this molecule again. If it goes to more than 6, then definitely you need to stop this molecule. So some of this trial data of eplerenone, which I would like to emphasize, is MI Ephesus trial. This is basically patients with LV dysfunction. Again, from any cause, again, large trial with more than 3,000 patients, death from any cause or death from cause and hospitalizations are significantly decreased in a subgroup of patients in which eplerenone was given, apart from the standard other guideline-directed therapy. So it concluded saying that acute MI 30 days mortality, when started within 3 to 12 days after MI, it decreased mortality by 30% over the placebo, decreases mortality and hospitalization by 13%. Cardiovascular mortality is more beneficial. And what is also noted is sudden cardiac death also is decreased. And this is another molecule, unlike beta blocker, this also is decreased sudden cardiac death, maybe by interstitial fibrosis mechanisms and decreasing arrhythmias, other things which have to be seen. And then eplerenone, when you see specific diabetic subsets, the benefits are more compared to non-diabetics. That's how it's important for us to recognize. Then systolic heart failure, emphasis heart failure trial was also done. This is not post-MI. Anybody who has less than heart failure, pumping function of less than 40 was studied in this group. Again showed that this molecule does good to these patients, decreasing mortality and heart failures, hospitalizations. This post-hoc analysis of emphasis heart failure again showed in any subgroup of patients there is significant benefit with this molecule. Then what this post-hoc analysis concluded is initiation of eplerenone early after discharge. You did not start it immediately after MI, But even after post-discharge, you started, still these patients having benefit with this molecule. So we were worried little about advanced age, diabetes and CKD, and low systolic blood pressure. One thing in clinicians we need to know is whenever the risk is high, the therapy intervention, the benefit will be also most, provided you give it right. It's very important for us to understand. Same thing with CAD, acute MI, ACS, where mortality risk is high, the benefits of treatment would be also high. Similarly, this is very important for us to identify the subgroup of patients who are little high risk. At the same time, properly give this molecule so that benefits are seen. Luckily, as I said, if you have seen the various trial data, the more than 6 going potassium is very less common, not significantly different. Only it tends to increase in between 5 to 5.5. That's how even in the subgroup of patients with advanced age, diabetic and CKD, you could still afford to give this molecule and give the benefit of this molecule because it decreases mortality substantially in these patients who have these risk factors together. And if you see Eplerenone in hypertension patients with heart failure, if a patient has hypertension along with heart failure, the percentage of benefit which this molecule does is more compared to those subgroup of patients in which there is no hypertension. That means all the more reason to start this molecule if a patient has hypertension and hypertension heart failure. So this study of Eplerenone, finally it said that AMI with reduced ejection fraction, it helps. And patients who have associated hypertension, again, the help is more, the benefit is more with this molecule. So if many of you must be aware of the spironolactone, aldactone, which was there before, but you had the side effect of this progesterone side effects leading to gynecomastia, and sometimes longer half-life could lead to more trouble. This molecule has shorter half-life and less causes of gynecomastia and vaginal bleeding. Again, proven itself that it is safe even in high-risk groups like borderline potassium and creatinine values. If you see, when you compare the Eplerenone clinical benefits, again, if you the all-cause mortality and hospitalizations were not different between these two molecules, but obviously side effects were much less. If you see this cartoon which shows the spironolactone versus Eplerenone, the gynecomastia incidence was 0 in the subgroup of patients with Eplerenone. Then that's how this is a more safer molecule and which has good effects of all the effects of aldosterone antagonism with less side effects, sexual side effects, and better tolerability in these patients. Now we go on to another important molecule of day, Tolvaptan. Tolvaptan is again oral non-peptide selective vasopressin 2 receptor antagonist. So basically this acts in the distal collecting tubule in the nephron. What it does, we know antidiuretic hormone, ADH, generally prevents more urine going and absorbs the urine from going in the body. And whereas this molecule, vasopressin or tolvaptan here, binds to this and then entire complex, the receptors formation is decreased. That's how absorption of water is decreased. That's why more urine excretion happens. And that's how relatively sodium gets concentrated. And then you have effectively more of urine loss and more of preservation of sodium. If you see, tolvaptan is highly protein bound, and 2 to 4 hours after this, the effects start. And if the tolvaptan, again, trial to recapitulate, basically the Everest trial, this is again done. Initially, some of the smaller trials were saying that sodium using this tolvaptan could be beneficial in heart failure. Edemas decreased, weight decreased, and this trial was planned to see the long-term effects, whether it could produce mortality benefits. But primary endpoints were not different, but secondary endpoints like dyspnea decrease and edema decrease were significantly better when this tolvaptan was used in the heart failure patients who have severe early dysfunction. And then you see this sodium increase happened better with tolvaptan group, unlike those patients in which are on placebo. And these drugs also very pleasantly did not increase mortality, because we had seen some drugs which increased mortality and caused trouble like digoxin. But here, the all-cause mortality and the cardiovascular, though it did not produce benefit, but at least it did not increase also. So this tolvaptan drug is one which decreases weight and improves sodium levels. At the same time, no worsening of heart failure or increase of mortality. The safety profile, just for a little of thirstiness and dry mouth, most of the side effects are not there. It's as good as placebo. So that's the safety of this molecule and less side effect prone. So the Everest trial concluded saying that this is again important, potentially useful agent for treating patients with exacerbation of heart failure, with significant benefits of dyspnea, decreased body weight, coupled with the neutral effect on preservation of renal function and no increase in mortality. That's good news with this molecule. And this molecule, when the meta-analysis was done, again, in various subgroups, this molecule showed benefit when used in these patients. And sodium levels, again, patients who have more low sodiums benefited, but patients with normal sodium values also it is benefited. So what this concluded is, comparing the standard diuretic therapy, if you add tolvaptan to this diuretic, probably the incidence of worsening of renal function and the mortality did not differ, and the body weight and again sodium levels improved and body weight decreased in these patients of acute decompensated heart failure. So this is, again, we tend to use this molecule more in chronic settings when you have hyponatremia on follow-up in these patients, but actually it is first tested even in acute decompensated heart failure patients. This graph shows that change in the body weight, decreased body weight, and improving urine outputs, and then probably decreasing, improving the sodium levels. That's how this molecule in the real-world setting decreases the lymphedema, pulmonary congestion, decreases jugular venous distension, and hepatomegaly and dyspnea. What all the classical signs and symptoms of heart failure are coming down with tolvaptan. Mind you, there's no mortality benefit. It's difficult to have mortality benefit with every molecule. So tolvaptan in the real-world setting should be used in patients, especially when you find some diuretic resistance, not improving, and then probably you have a hyponatremia or a normal sodium levels, and then this molecule is recommended even in normonatremia, especially when the patient has fluid overload. So that's the real-world usage of the tolvaptan. If you see this, as I said, downhill course of heart failure happens, acute heart failure worsens, and in between, the rhythm abnormalities could develop and could benefit by the ICDs and other therapies. And as a patient worsens further with more pump failure, he could go into many support devices and transplant, which are beyond the scope of today's discussion. So thus, to conclude, what I would like to mention is heart failure now is increasingly prevalent syndrome, and all of us should have our high suspicions in these patients who present with breathlessness and recurrent hospitalizations, readmissions. Now we have various new drugs which have come, like ARNI, and again we have to resurgence. We should know more about these older molecules of Eplerenone and Tolvaptan, which could do additional good to these patients and thus decreasing the hospitalization rates. And we should be also aware of this other entity of heart failure with preserved ejection fraction. Eplerenone is again oral and under aldosterone antagonist, which is useful for hypertension as well as heart failure, especially post-MI LV dysfunction. And we have data now to show that post-MI LV dysfunction, significant decrease in mortality happens and hospitalizations decrease with this molecule of eplerenone over ACE inhibitors, ARBs, and beta blockers. And so that with again, eplerenone has no side effects, unlike aldosterone antagonists, and even in patients who have borderline renal dysfunction and hyperkalemia, hypokalemia, diabetes, still it is found to be safe. And what about closing? What about tolvaptan? Again, a novel oral non-peptide antagonist, which is again used to treat hyponatremia, also helps in advanced heart failure patients in decreasing weight and conserves sodium and decreases dyspnea, and also preserves renal dysfunction, no worsening of renal function, no increase in cardiac morbidity and mortality. I think with this, I would like to close. Thank you very much for patient hearing, and we hope we will have some discussion. Whatever doubts anybody has, presenters have, I can see it in chat, and we have some panel discussion. Then this question. Thank you again for your patience.
Okay, thank you very much. Hello.
Yes, go ahead, please.
Hello, good day. Sorry, I'm back. I had some issues with my network. Hello.
Yeah, we are able to hear you. See you. Go ahead.
Okay. So thanks for the presentation. That was a very good one on the role of eplerenone and tolvaptan in heart failure. Probably we could type our questions in the chat. Trying to see if there's any questions. But if anybody who wants to ask a question, can we have some questions?
Panelists and moderators here. Then we'll go to the chat for the taking questions. Okay.
But probably if I could ask a question.
Can you close the slides and make everybody bigger here? Technical team.
Hello, can you hear me?
Yeah, we can hear you. Go ahead.
Okay. Probably I could start with asking a question. I noted that compliance issue was a big problem in managing heart failure How do you cope with this in your practice?
This is a very good question. Can you make the screen bigger? Remove the slides and make everybody bigger? The technical team. Anyway, I will. That's a very good point. Actually, I highlighted it also in my talk that one of the main reasons worsening and repeated hospitalization happening is one is disease progression, which is again we could do something with drug ophthalmology. Can't do too much about it, but wherever there's a treatable factor, that's very important for us to treat. One of the most important is drug non-compliance by patient and patients eating more salt and not taking rest and other things. Doctor asked a very pertinent question: how to improve the drug compliance in these patients of heart failure? I'm talking slightly slowly because some of the people might think that I'm too fast in this, but I'll try to be as much slow as possible. Basically, whenever somebody has to improve the compliance of taking the drug therapy, what we need to do is you educate the patient. Health education about his disease is important. You tell him how, if you take the medicines properly, the mortality can decrease by 60% compared to those groups in which mortality is not normal, that is very high without this treatment. That itself makes the patient worry little about his disease, probably would become little more compliant, number one. Number two, suppose patient is not educated, is not able to follow properly, what we can do is, if we can give this long-acting molecules, then compliance of these patients would be better. In the sense that if you give a molecule like captopril, which has to be taken 3 times, 4 times in a day, then patients obviously will be more non-compliant. Unlike that, you prefer a molecule like ramipril, which has 24-hour action, probably patients should be more compliant. Same thing with sacubitril valsartan or the newer molecules. That's how the long-acting preparations in beta blockers and everything has come to improve the compliance of these patients. Fortunately for our molecule of today's discussion, eplerenone also can be given once daily. In hypertension, sometimes you may tend to give twice daily, but generally once daily. And same is the case with Tolvaptan. So what other words to say is to improve patient education, knowledge about it, and make him aware how the treatment taking would improve his outcome. And again, giving him little long-acting medicines could help in improving the compliance. Obviously, this is a challenge in spite of we telling, and patients, once they become less symptomatic, they tend to neglect their medication, tend to neglect their food intake, take more of salt, and that's how worsen. This is a continuous process of education. Thank you, doctor, for bringing out this point, which is very useful in managing heart failure patients. Think of any other comments? Thank you.
I think there's a question. Hello, thank you very much for the answer.
Thank you.
There's another question on the chat.
Yeah,
before we go on to
chat, can we ask some comments from these other 3 panelists? Dr. Shaman, tell me, sir.
Yes,
yeah.
Dr.
We'll bring the panelists later.
Okay, no problem. Whatever it is. Okay, no problem.
Okay, go ahead, please. Yeah.
The question is that for how long can we give Tolvaptan safely? And how often do we need to monitor sodium? That was a question on the chat.
Yeah. Actually, it's a very good point. That is initially tested in acutely heart failure trials with only about 6 months. But later on, long-term studies were also done up to 2 years with this molecule, which again showed that this molecule is quite safe to be given in long term. No increase in mortality, no problems. And on the other hand, decreased weight and improved symptoms have happened in these patients, and sodium improvement also happened. If you are trying to look for improvement of sodium, some patients response varies, but I would say obviously it starts improvement in 4 to 6 hours once the drug starts acting. But optimally, probably after 48 hours, you check the sodium levels once. If a patient has a normal level, you need not repeatedly check it. If a patient has hyponatremia, till he improves, again you check a little more closely. Later on, you can check it once you have how you are checking sodium, potassium, creatinine. In other words, to say in patients who have acutely ill heart failure with low sodiums, you check it a little more frequently. But in long-term follow-up patients, again, you need not check so closely. Yeah, shall I read this chat? Or go ahead. Not able to hear. Unmute it.
That's okay.
Yeah.
Can we take 2 questions and then bring the panelists? Hello.
Yeah, go ahead.
Yes. I have about two other questions in the chat. Somebody's asking about drug interaction with eplerenone, and can you combine tolvaptan with sodium chloride tablets? Patient with hypothermia. While you can answer that, then we can bring in the panelists.
Sorry, what did you say? Eplerenone? Didn't get the question.
Any drug interaction with eplerenone.
Yeah.
And then also comment on the combination of tolvaptan and sodium chloride tablets in management of hyponatremia and heart failure.
Yeah. Eplerenone, that's a good point. Again, cyto-CYP enzyme-mediated pathways, whichever the drugs like azithromycin or erythromycin or antifungal drugs which have CYP cytochrome P450 pathways could have interactions with this molecule, which we use less commonly in this heart failure patient, though sometimes if you has fungal infections and antibacterial infections, you could use this, but you tend to avoid those molecules with use of this. By and large, otherwise, this is reasonably safer molecule. Combination of tolvaptan and sodium, probably sodium giving may not immediately increase it, but if the patient is too sick and if you can take orally, we encourage them to take some oral sodium, especially mixed with buttermilk or water and lemon juice like that, and give this tablet too. And then probably you will never go to very high levels of sodium. For human body, that way is great, I feel. There's a lot of mechanisms to control too much bad things happening. I've not seen patients who are having, though it is described theoretically, very high sodium levels can damage the brain, and very low sodium can also have damage in brain. But theoretically, we have seen many patients with low sodiums, but not with very high sodium levels. So you need not be worried too much by giving the combination of tolvaptan as well as some sodium replenishment in diet. And if you see patients, so human body again tends to grade. I say I have seen patients walking with 120 sodiums also. We would be sometimes unbelievable, but still the way it is getting repeated also helps. I think human body gets adjusted over a period of time. And that's how we tend to see the varied patterns of sodium in heart failure in patients. Many of the questions I see in the chat, that I thank you, many of them, for appreciating a nice presentation. But can I have the slides they're asking? I'm happy the MSN can share the slide set with anybody. I always believe in knowledge should be distributed. I have no issues. Anybody wants to download these slides, please, the technical team or MSN can hand over these slides to any of the doctors who wants. And I can now, Dr. Shamlal sir, you're saying something. The slides not now. Later on, you can, any doctor who wants to download the slides, you can give it to them. No problem. I have no issue.
Thank you. Thank you so much.
The slides now. You can put back the pictures of doctors. Okay. Go ahead, sir. Shamlal sir is telling something.
Can we just bring in our panelists, Dr. Ulrich, Dr. Lingo, and Dr. Olga? Probably briefly, we can just have you share your experience and then on the topic discussed and what are local experiences. Probably we can start with Dr. Lingo.
Hello, can you hear me?
Dr. Lingo, can you hear me?
I'm not able to hear you.
Dr. Kilingo.
Can you hear me? Yes?
Yes, I can hear you.
Sir, what is better is I can see the chats here. I can keep answering those because sometimes the disturbance of mics will not be there. So you can mute your mic and I go on answering the chat. Is that okay? Yeah, Shamlal sir is lifting his hand.
I think Dr. Adewole, I think you should mute yourself because there is lots of noise from my side, from your side. Because we can hear Dr. Sreenivas well, but when you speak, I think there are lots of parasites.
Yeah.
I think. Is it better? We are still getting lots of parasites, Dr. Sreenivas.
From my side, you're getting no.
No, I think it's from the moderator side.
Yeah. I think you can ask something, sir. You are telling something. You can ask a question. All others, mute your mic.
Hello.
Yeah.
Yes, sir. It is some. I guess it is from one of your side because I have tried to mute, but still it is coming. Now it is not coming.
Now
Okay.
it is perfect. Yeah, now it
Now
is
it's okay. Yes, sir. But still, now it has started.
No, somebody's cell phone is ringing there. Okay. Go ahead, sir.
Yes, Dr. Sreenivas. I think, is it from my side? I don't know. But, thank you for the presentation. I just wanted to, it's not a question, I just wanted to add a comment
Yes.
that we have all been treating heart failure patients, and we have seen that adding valsartan sacubitril, I have seen in my patients, it does wonders, right? And on top
Yes.
of that, when we add eplerenone, and Tolvaptan at last, when the patient is still retaining water, where we need to remove water, I've got very good results. Tolvaptan we are not using much because we don't have it in the hospital, but in all the patients I have used in private sector, I see there is a lot of amelioration. The patient, especially with valsartan and sacubitril, this is a drug, when I have used it in my patients, they tell me, like, doctor, I don't know what you have done to me, but I feel much, much, much better now.
Yeah, symptomatically and symptoms wise, they appear as if they do very well. That's a thing which we noticed, because vasodilatory molecules are helpful in these heart failure patients. Something like giving steroids to this patient. These patients of heart failure improve dramatically. As we understand, the tolvaptan is one which is used in more sicker patients, whereas Arni is actually one which is actually used in even the patients who are walking, class 2, class 3, class 4, anybody, and it does good, sir. I see more of hair grown here on me because of COVID. I see you more here and then the reverse of it. And what is the situation of COVID in Mauritius, sir?
I can say in Mauritius, we have been a bit fortunate that we have been able to control the infection almost, you can say. We got 330 cases down here, but since the past 5 days, we didn't have any case. Then we got 2 yesterday.
Okay.
And the number of deaths are only 10. That means it's a mortality rate of 3.3%.
Lockdown is on or lockdown is open now? Public is
Our lockdown is still on, but the
Okay.
supermarkets are open so that we can just go and buy stuff. But we go according to your names, like, some alphabetical order. Then not everybody is going to the supermarket every day. But in general, we have been able to contain it quite well. It's a very sad day today for us because we got our first doctor who passed away yesterday, and his funeral was today. He was head of Department of Internal Medicine. He was
suffered with COVID.
Yeah, because of COVID. Actually,
Oh.
he saw the first patient of COVID in Mauritius, and that patient, somehow he didn't give a proper history and he didn't protect himself, and he got infected. He was intubated in the past 3 weeks now, and he passed yesterday. His funeral was today. So it's a very dark day today. It's the first doctor who passed away of COVID in Mauritius today.
Very unfortunate, because personal protection and each of us protecting ourselves and keeping ourselves clean, I think it's very important for us to prevent. What is the status in Nigeria and Kenya? Other doctors can speak. Sorry, I'm deviating a little, but I'll take 1 minute to get the information firsthand from these doctors.
Sure.
Yeah. Can you mute others' mics, please? One. I'll take the questions. Don't worry. I'll finish all the questions before we conclude.
Okay. Dr. Devi, you want to speak?
Yeah, what is the...
Go ahead.
Okay. Well, we're over 1,000 now. About 1,000, almost 1,500 patients of cases. About 40 deaths. We're still having more cases, but hotspots in the country is the commercial capital, the political capital of Nigeria, and a neighboring state. The lockdown is there, especially in Lagos, in the neighboring state, and Abuja. It's quite a difficult situation, but the Center for Disease Control and the federal government and the state governments are working hard to see how disease is controlled in the country.
Great. I appreciate all your commitment and so much interest you have in the scientific data presentations. All of you joined in spite of all the tough time, and we should thank MSN and all of you for joining these words. I think we can take information from other two doctors. I will take few questions, and before we conclude, we can take any other things. You want to say anything, sir, here before we go on? I'll read the question chat in the chat box. Is it okay? Or you want to say something?
Maybe I think your presentation actually I love it so much, especially in the area of the problem of a heart failure patient, which is readmission. I think again that is the most common problem that we have in this part of the world, and makes the patient miserable. I mean, when they get admitted over and over again. And I'm happy the way you looked at it, looking at disease-related factors, the system factors, the patient factors, and the support system factors. And these are the areas as healthcare providers we really need to, for every patient, to take those issues one by one in order to reduce their readmission rate. Because once they are readmitted, the tendency of having complications or even dying is there. And once they are readmitted over and over, the probability of dying is also there. And then they also lose, trust in us, because the patient comes to the hospital, they want to be treated, they don't want to come back again. As much as they are coming back, they feel that our medical and the medicines are not working, or that they can look for other alternative ways of getting care, which usually they don't get. That's my own comment.
Yeah, great, sir. That is very important for the patients to be taking these drugs correctly. And that's how I try to highlight that aspect.
Hello, Dr. Silmanis, can you hear me? Dr. Silmanis, yes. Can you hear me? This is Dr. Kilingo.
Okay.
Hello.
Dr. Kilingo, you can go on. We are hearing you.
Yes.
You can go on.
You can hear me now? Thank you very much.
We can hear you.
Okay. Thank you very much for the presentation. My pleasure to be with you this evening. I just wanted to, probably before we proceed to the other questions, you clarify something, because there's something which is common to us, Africa and India, and that is rheumatic heart disease.
Yes.
And obviously what you've talked about is other typical patients with probably cardiomyopathies from hypertension, diabetes, or whatever. But these patients who have valvular heart disease, does it really, benefit? Does it translate? In my experience, I'm not seeing like these patients who are rheumatic heart disease, they come in heart failure with reduced ejection fraction, you may say so. But even with the, all the optimal medical therapy, they probably will not do well. So would you please probably emphasize that the etiology, like rheumatic heart disease, probably the patient is not going to get as much benefit as the other conditions of that cause heart failure.
Yeah, that's a very important point, doctor, because I generally didn't touch too much on rheumatic heart disease, because our country, somehow it is decreased. I was forgetting that I'm talking to a lot of colleagues from Africa. Very important point, you brought it out. Thank you very much. And rheumatic heart disease, any valvular heart disease for that matter, any heart failure for that matter, our duty is to see any etiological factors which could, once you treat it, could reverse the heart failure. Like severe mitral stenosis is there. Once you open up and do a balloon mitral artery, patients improve dramatically. Now you have patients who have mitral regurgitation or aortic stenosis. If you treat it, again it improves. I would like to mention and share to all of you that aortic stenosis, aortic regurgitation, which was only in a surgical domain before, now we started doing TAVRs, trans-aortic valve replacements, and then patients improve dramatically. I have seen 70 years plus patients with heart failures, not able to lie down flat. Once we do TAVR procedure, improve dramatically and able to go home within 72 hours. I appreciate your points. Any valvular heart disease, be it rheumatic or be it degenerative, it has to be treated. For that matter, any secondary cause is there for heart failure. We have to find out and then probably treat it. And thanks for bringing out that point.
Thank you.
Excuse me, please.
I will.
Yes. Hello.
Yeah. Hello.
Dr. Kilingo.
Yes.
Hello, Dr. Kilingo.
Yes.
What's the contribution of rheumatic heart disease to heart failure in Kenya? Because here in Nigeria, at least where we practice, rheumatic heart disease contribution to heart failure is very minimal. What's the experience in Kenya?
Now, my experience, like like where I work, I have the advantage of working both from Nairobi and one of the counties in up country, and in the county of Nakuru where I work most of the time, I see a lot of young people coming in heart failure, and only to do an echo and find actually what they have is rheumatic heart disease. I will say that in my practice, probably about 20% of those patients are rheumatic heart disease. And it's very frustrating because some of them are so late for surgery. Actually, the injection fraction is about 20%. You can't even talk about surgery. They are so sick, and despite all the optimal therapy, most of them don't end up doing well. So the point is, of course, is to identify them early, before they get into complications, severe heart failure for surgery. And of course, the problem again is that we are not able to do surgeries in time. There's a lot of backlog. There's only probably a few centers that are able to do, heart valve replacement surgeries, and not many patients also can afford the same. So you get those patients with, those chronic valvular disorders in heart failure coming to you, and most of them are even adults, and so they are just helpless.
Yeah, that's again important. Don't wait till the worsen and they become too sick. That's how the therapy, we know that the earlier you intervene in these patients of heart failure before they become totally large hearts and dilated hearts with LV dysfunction, they do badly with surgery also. As we are become more and more experienced, the more early you operate these patients and probably repair these valves, it could be better. And that point again is well told, and probably in India is slightly better off with the lesser incidence of such worse heart failures because they're picked up very early with low-cost insurance schemes, which we have. Many of these patients who are not able to afford before also go for early surgery in our country. Now we have Prime Minister's Pradhan Mantri Yojana as well as Aragashree schemes in our country, which help these poor patients to go on. I think we are nearing the time. I would take some of these questions, please, if you don't mind, because I promised them that we'll finish all these questions. Some of the things I think MSN folks would be very happy. Some Dr. Bhakthovar, he said, "Thank you, Dr. Sreenivas, very nice and clear presentation. I'm sure we will now prescribe more of these drugs to our heart failure patients." I think you'll be happy, MSN. Then many of them are just appreciating nice presentation and all that. How long, other question from Dr. Akrabi is for how long we can give Tolvaptan safely. I think this part we already covered. And thanks for lovely presentation, interesting presentation, great presentation. We have quite a number of our heart failure patients with hyponatremia. Very useful talk. And thank you so much for nice presentation. Evidence-based new products for heart failure. Yes, whenever I believe in any presentations, if you present the evidence to doctors, most of the doctors who want to go to patients gets convinced about it. That's how we should encourage proper research, and that's how these molecules are very strong basis for thing. And one thing which I wanted to highlight is if you don't treat these heart failure patients, we should always make this point clear. Heart failure is more malignant than malignancies. I have shown the slide which shows that 50% of the dying within 5 years, and it's much worse than many malignancies, which like Hodgkin's lymphomas or breast cancers, things like that. That point, if it should be kept in mind, and with these molecules, we can improve the mortality up to 60%. That's again a very significant number of patients. We can save 60 patients out of 100 patients if we can give guideline-directed therapy. That's the strength of these latest drugs. The only thing is sometimes I keep wondering, we have ACE inhibitors, we have beta blockers, we have mineralocorticoids, we have statins, we have antiplatelets. A poor patient has to take on so many drugs. But what to do? Because if they are suffering with so many diseases, you have to give this molecule and they have to take. So the long-acting preparations will help. Sir, tell me, sir.
Dr. Sreenivas, I wanted to ask a question. Where do you place ivabradine in your treatment of heart failure?
Yeah, because because it was becoming too lengthy, I didn't touch upon too much. But whenever you find a heart failure patient, in spite of using beta blocker, his heart rates are very high. Normally, if heart rate is about 70, still it is okay. But if it is sometimes you see very hypertensive drive states where patients' heart rates are 100, and you're not able to step up beta blockers also sometimes because of worsening of failure. Those are subsets of patients who benefit most by ivabradine. And where you're not able to give beta blocker because of non-tolerance or heart rates are high in spite of beta blockers. Those are subsets of patients which benefit by ivabradine. But now with ivabradine SHIFT trial and all show that that is another molecule which could decrease mortality. patient can afford it, you can use it in all the patients, but definitely for patients who have high heart rates in spite of using beta blockers. Actually, we started using this drug even in acute settings like septic shock-like situations and where heart rates are very fast. Also, we tend to use this molecule just to control the heart rate. And without causing any negative inotropic effects, worsening of heart failure, still the rates are controlled. That's the beauty of that drug. I think another question is whether dosage modification to be done in low GFRs. Most of the time, fortunately, it is excreted to other routes. So probably unless it is stage 5 CKD, you need not worry so much. That's what the trial showed, that worsening doesn't happen with these molecules. But only thing is when they're totally shut down, then probably you need to be a little careful. How available is Tolvaptan in Nigeria, and what is the cost implication in a resource poor setting? That I think MSN folks should answer it. Most likely it is there in Nigeria. I think one of the...
Right now it is not.
Okay, not there. I think they should be able to tell you, and you can interact with them. Yeah?
Will personally, our team will go and meet the doctor, and we will discuss.
Okay. My network is breaking, voice is bad, different position there. What is the different presentation of Tolvaptan? 15 milligrams and 30 milligrams as of now. The data is there up to 50 milligrams. Mahesh Trivedi, thanks for the nice presentation. We wish we can have these drugs to improve quality of life for heart failure patients. This doctor is from which country? Is it not available there? Dr. Mahesh Trivedi is from which country? Please, one of the representatives go and meet the doctor. Okay. Then great. Thanks for the presentation. Thanks for how do you adjust this drugs management in advanced heart failure patients with first degree heart blocks and hyponatremia? This is a very good question. I think before we close, I would just clear this. Any patient who's put on these molecules, it's our duty in medicine, it is to do no harm to patient, leave out the benefit. So first duty dictum is do no harm to these patients. If a patient who is likely to worsen with this molecule, we should immediately pick up and stop this molecule. That's what I mentioned. But fortunately, these molecules are relatively safe. And even if a little worsening of potassium is happening, nothing to worry. If up to a level of 5.5, there is no problem. But 5 to 5.5, we decrease the dose of these drugs as recommended, make them half. But if it is crossed to 6, then definitely you should stop this molecule and recheck this potassium levels after 3 days and then try to rebuild it. And with first degree heart block patients, and again any heart block for that matter, you need to be careful whether it is degenerative process which is leading to heart block, or it is per se secondary to any of these electrolyte imbalance or what we need to see. Generally, blocks are seen more with hyperkalemias. Rather, sometimes if patients have already gone to stage of heart block, that means you would have significant abnormality of potassium. And the hyponatremia generally has more fatigue and weakness, and does not cause too much of problem. Though theoretically, it is said that too much low potassiums of less than 120 or high potassiums of more than 50 could lead to white matter degeneration in brain and cause some significant problems to the patients. Fortunately, we have not seen much. I think I've answered most of the questions. I fulfilled my promise that I will not leave unless all the chat questions are answered. Is it fine? I think I'm very happy in this COVID times. Also, 150 doctors from various countries have logged in. I hope this was useful for all of you. And if we have no further questions or comments, we could close. What do you say? Any other closing comments? Anybody?
I will take some comments from the panelists. Probably the last comments from each of the panelists before we close.
Each panelist you can take last comments before we close.
Yes.
And thanks for giving me information about COVID also.
Last comment is Dr. Sreenivas. Thank you, and I would like to thank MSN for this forum. And we hope that we can get such video conferences, webinars frequently, because it will be very difficult in the coming 6 to 9 months to attend any conferences. So we would like to get such conferences. Thank you, everybody, for being present here.
Thanks, sir. Thanks for coming in spite of tough conditions.
Thank you very much. I want to align with the last speaker. We appreciate you so much. And the speaker, you did an excellent job. We really want things like this just to keep us busy, especially in these trying times. Thank you very much for the brotherhood and collaboration.
Thank you.
Thank you. Dr. Kilingo?
Mine is to say thank you for the talk and to thank MSN because we are lucky. We have most of the medicines in Kenya. Even in the local town where I work, we have Tolvaptan and we have Eplerenone. So, and they are affordable. Most of our patients are getting the benefit of these drugs.
Great. MSN is making India also proud. We're making all these products at low cost for the benefit of our patients.
Yes.
Yeah.
So,
That's true.
just round up. Thank you so much, Dr. Kumar, for the presentation. We really enjoyed it so much. And the panelists, we are so grateful to have you. And then MSN, thanks so much. But we are asking for the drugs in Nigeria, Tolvaptan especially. And well, I know you're about to launch Eplerenone before the COVID issue started. But and then more of your molecules, we appreciate it in Nigeria. Thank you so much for a brilliant session. Thanks.
Okay, any closing comments from MSN? Anybody?
Yes.
Right.
Yes, I would like to say a vote of thanks to all. Sir, first of all, I am Dipankar Jha. I am cluster head for West Africa for MSN. On behalf of MSN, sir, thank you all for participating in this online webinar. Sir, especially I would like to convey my gratitude to Dr.A.Sreenivas Kumar from India for an interactive speaker session. Then Dr. Adebi from Nigeria for moderating this session beautifully. Then Dr. Kilingo from Kenya, with whom I am known for last 5 years. Dr. Shamlal Umesh from Mauritius, thank you very much for your participation, sir. Then Dr. Oga from Nigeria. In fact, he is the president for Nigerian Cardiac Society as well. Thank you very much for accepting, all of you, sir, for request to be part as panel members for this. In fact, sir, I would like to thank all our esteemed delegates for taking time and participated in this session. I am sure COVID-19 will leave us more strong and committed to family, society, and each other as fellow beings. MSL Labs will continue to serve patients with innovative and first-in-class medicines, and we seek your warm support in this endeavor. Sir, we will keep trying our efforts in making this Hyd.Live more interactive. Thank you very much, sir. Thanks a lot, sir, from MS.
Thank you, bye-bye, and hope all of you enjoyed this. I would also like to invite all of you for TCT meeting, if it is virtual or real, can join it, and MSN people would help you in participating. And the other good comments, I am very happy to see that. One other doctor, Dr. Shamin from Mauritius only. Most welcome again to Mauritius, sir, for other updates in cardiology. Anyway, thank you one and all. And we'll again hope to meet and have more such webinars and meet personally too. Thank you again. Shall I close?